Yes, I'm a consultant neurologist from Rashid Hospital and the president of Emergency Neurology Society. This is the second day of the update series in MS. Yesterday, we had a wonderful day with Professor Chen that we spoke about MS emerging in the treatment. And then we had Dr. Talib Mansour, who spoke about MS mimics. Today will be another 90 minutes of wonderful two speakers. We will start with Dr. If I will change the order here, we will start with Dr. Muna first, if she will not mind to start with her. Dr. Muna will speak tonight about the caring of MS patients remotely. Dr. Muna is running one of the largest MS clinic at the level of Saudi Arabia. Currently, she is a consultant neurologist at the Neurosciences Department, King Faisal Specialist Hospital and Research Center in Riyadh. Dr. Muna is one of the leader of MS at the level of the Middle East, and she's a good one of the pioneers researcher and a good speakers. I would like to ask Dr. Muna to start her presentation. تفضلي دكتورة منى.
Assalamu alaikum. Good evening, everyone. Am I heard well? Excellent. Thank you so much, Dr. Rukun, for your honorable invitation. I am very happy to be here with you and for this very exciting event. And I will start by sharing my screen. Can you see my screen? Okay, super. Okay, so, you know, in the midst of COVID-19 situation, I think this is a very important topic to consider. However, bear in mind that this is something that's going to stay with us, not COVID-19, hopefully, inshallah, but the virtual neurology or the remote caring for multiple sclerosis patients and neurology patients in general. I am very pleased to be here once again. Thank you very much for your invitation, and I hope you will enjoy this presentation. March 11, 2020, the World Health Organization declared COVID-19 as a pandemic, and this has impacted our lives at a personal level as well as at a career level. I think there is no one that was exempt from this big hit, and it has changed a lot in the way we think, in the way we practice. And I think we must look out also at the bright side of this crisis, if you will. Now, since the pandemic has been declared, a lot of prestigious institutions have shifted their work towards the remote caring for the patients. Duke University Affiliated Hospital is no exception, where there is an increase in the use of televisits over 1 month only, from less than 1% of the visits prior to COVID-19 to 70% of the patient's visits. That amounts to 1,000 visits per day. Examples all over the world, including other prestigious places and other hospitals in the Middle East and other places as well, I believe. And our hospital, similarly, we extensively utilized the tools that were available to us to conduct virtual visits. Of course, King Faisal introduced the concept of virtual clinics many years ago and been very interested in cultivating this tool and these resources, and it's been proven to be very helpful and very efficient. Now, definitely, there is much more to the virtual neurology than only bridging the care for MS patients during the pandemic. And given the amount of money, time, and everything that we invested to improve the infrastructure of this kind of approach, it just doesn't make sense to let go after the pandemic passes. I think this is something that we will continue to practice, and it will continue to be a complementary to our usual or routine care for our MS patients, as well as other neurology patients. And as Dr. Shah once said in a recent publication, telemedicine is indeed crossing the chasm between being just an interesting, rarely used technology to an essential one. Now, e-health is a term that refers to all sort of, digital uses of digital sort of platforms from social media and scientific knowledge dissemination through online channels to using assistive technology, the applications in your smartphone, what we wear in our wrists, the smartwatches, for example, also included technical tools used for neurorehabilitation. It's a very broad term that includes a lot of things. Telemedicine, on the other hand, is perhaps a more specific term that was coined by the World Health Organization in 1970. It's defined as the delivery of healthcare services where distance is a critical factor by all healthcare professionals. So we're not only talking about doctors here. We're also talking about nurses, health educators, psychologists, rehabilitation specialists. So we're doing that for patients at a distance using the technologies, the information and communication technologies, to exchange valid information, diagnosis, treatment, prevention, research, evaluation, continuing education for healthcare providers. And this is all in the interest, of course, of advancing health of individuals and their communities. This is a very interesting thing that I came across when I was preparing this presentation. This is the cover for the Radio News magazine in 1924. It's depicting, as you can see here, a sick child in his bed sticking out his tongue to his doctor who is at a distance with a camera and you know, what they've envisioned for a speaker and a camera and everything. And this was considered a futuristic look. And people who are quoting this cover, they say the future is now. And it's indeed, the future is now. And we are seeing this no longer it's a sci-fi or imaginary, it's a reality. And it's been evolving. The telemedicine has been evolving over the years, and the earlier developments were to serve perhaps mainly the space and military sections. And the earlier milestones were when we used to conduct the EKG information data over the phones, as you can see here in one of the photos. But there are many other examples of how telemedicine progressed over the years and how it was utilized by different sectors and different specialties. As you can see, for example, I think this picture refers to a psychiatrist, if I'm not mistaken, who's giving a consultation to colleagues, general doctors in some of the rural areas, perhaps. And another pictures is showing you that you can transmit anything from still images to recorded data to videos, and just there are so much potential to this. In general, there are two basic types of telemedicine: the synchronous, where the individuals involved in this kind of exchange are present simultaneously, or asynchronous, where the exchange of pre-recorded data happens between two or more individuals at different times. And in either types of telemedicine, it could be either between two health professionals or between a health professional and a patient, for example. And in either type of information, the transmitted data can vary between text, audio, video, or even still images, all kinds of data. And typically, telemedicine has been utilized for monitoring chronic conditions in order to detect early signs of deterioration, to provide treatment or even rehabilitation, as we will see in a few slides, to provide education and advice for self-management, and also to acquire a second opinion from highly specialized people, sometimes physicians with very rare specialties. It could also be used for real-time assessment for clinical status of certain diseases, and also for urgent cases to assess the need to go to the ER. And sometimes utilizing this technology, you can actually prevent unnecessary visit to the emergency room. Why should we consider and develop telemedicine? For a lot of reasons. Telemedicine gives us a tool to improve the access to healthcare to specialized individuals worldwide. It enhances the cost effectiveness of the healthcare system. It also can help us better serve underprivileged places in the same country or in other countries in the world. as well as it enhances the patient-provider communication. It makes it easier to reach for your treating physician and get their opinion on matters that might pop up between the visits. Think about how much time and money wasted on commute that will be saved when we use telemedicine for our communications or for our health care provisions for our patients. Let alone, of course, like times of pandemics, for example, and it's been successfully used extensively during COVID-19 situation. It also provides some sort of flexibility for the patient and the practitioner. Take, for example, the practitioner who wants to relocate, but to continue to cater to his patients. Or take, for example, the retired or physically challenged physician who cannot really go to the work every morning, which might be actually located at a distance from his residence. Also, think about when you want to provide some charity work to volunteer and how much easier that would be when you do it via telemedicine. Now, neurological diseases, we know it's a leading cause of disability around the world, yet the access to proper neurological care is unfortunately limited. So definitely virtual neurology can provide a substitute for the traditional care and will bridge these gaps in access and for either in low income countries or the high income countries. But the low income countries, it definitely will enhance the access to the less privileged individuals. And for the high income countries, it will be like sort of a luxury to be able to host the doctor at your home and talk to them without having to travel to their clinics. Dr. Bove, a very pleasant colleague I met virtually a few weeks ago, or probably several weeks ago, had made a nice, interesting study where she compared between 100 in-clinic and 50 telemedicine-based visits. The televisits were sooner follow-up after the regular, routine annual visits. She found that the telemedicine visits took shorter time, on average 30 minutes, half an hour, compared to the in-clinic visits, which took around an hour, and it was more focused on certain topics like symptoms management, reviewing results, educating the patient, counseling, answering specific questions of those. The interesting part is, now the majority of the providers felt very happy about these visits and felt that the remote examination was sufficient to address their needs, their patients' needs, and they were all able, interestingly, to perform all testing and evaluation they wanted to do that day. From the patient's perspective, again, the majority were either agreed or strongly agreed that they accomplished their goals through the telemedicine visit. The only probably deficiency I would say was in terms rating the eye contact. The eye contact was not maintained well enough when compared to the in-clinic visits. So to the author and her group, telemedicine might very well work in multiple sclerosis. 90% of the in-clinic and 100% of the telemedicine participants agreed or strongly agreed that their clinical goals have been met. 98% of patients thought technology was easy, and only a minority thought that person exam would address their needs in a better way. The majority of MS neurologists achieved their goals, and 3 ER visits were avoided, and a lot of costs were saved. A number of studies been out for many years about the feasibility of patients' acceptance and satisfaction with the telemedicine. It's not a very new subject, but of course you will see more and more on it since the COVID situation. And that is a review study published in Neurology in January 2020. And it basically looked at, it's by the telemedicine work group of the American Academy of Neurology. And the studies that were looked at, the conclusion from these studies is that the telemedicine visits were non-inferior for the evaluation patients' evaluation compared to the traditional in-person evaluations, and in terms of patients and caregiver satisfaction. And the evidence does support benefits in expediting care, increasing access, reducing costs, as well as improving diagnostic accuracy and health outcomes. However, studies are limited and there are gaps in knowledge that we still need to understand. Telemedicine doesn't only work for patients with MS in early stages of the disease. This is a study, the MAHA study. It was on patients who have an EDSS score of 7.5 or more, quite advanced in multiple sclerosis. And there was a group of healthcare providers that were working as a bridge between the specialized anesthesiologist and the general practitioners, and they were providing a monthly calls for patients in their homes. As I said, those are MS patients with an EDSS score of 7.5 or more. And when they evaluated the 2 years before this program and the duration and the period during this program, conducting this kind of monthly call visits, they found that there was a significant decrease in the number of individuals that are hospitalized, the number of hospitalizations, and the number of hospital days, as well as the total number of emergency treatment visits. Patient satisfaction reports and quality indicators were positive as well. If you looked at the North American Research Committee of MS registry, they surveyed a huge number of patients, and they were trying to understand who of these patients are more likely, or what are the characteristics of patients that are more likely to use the digital health and telemedicine for the provision of their care. And they found the younger the patient, the more comorbidities, the higher income and education level, the higher likelihood that they will be utilizing these technologies, and the more the benefits that are perceived by this group of patients. Telemedicine doesn't stop at diagnosis and treatment or treatment only, but it's also been studied and used for telerehabilitation. And rehabilitation is perhaps an stated for patients with multiple sclerosis. Rehabilitation is a super important part of management of MS patients, particularly those who have accumulated a degree of disability. Simply, unfortunately, of course, we do not have much to do for them in terms of disease-modifying therapy, but at least we can provide rehabilitation, which is really have been found to be very important in symptoms management, perhaps improving quality of life. And we know that we have limited access to programs for MS patients. Maybe telerehabilitation can be a part of the solution. And again, just like with telemedicine in general, there are two modes of delivery: the synchronous and the asynchronous, the real-time interaction, video conferencing with the rehabilitation specialist, or the remote or web-based rehabilitation where there is a pre-prepared program or schedule of exercises, education, and behavior modification. And this is just to show you the potential benefits, but also the potential barriers to this form of treatment or this form of rehabilitation. Of course, we're talking here about convenience, access, decreased travel time. And remember, these are patients who are disabled with variable degrees of disability. So the commute is also a unique challenge for this group of patients, unlike perhaps in other diseases, in other areas in medicine. Neurology patients and MS patients, especially advanced MS patients, are or can be disabled. Now, the barriers include things like, for example, we do not know which patients group that will benefit the most of these programs and what are the programs that will work most efficiently with them. There is a loss of group effect. Safety, that these patients might have problems with their balance, with their weakness, and they might injure themselves if they were not directly supervised. So this is something that has to be studied further and understood. Virtual reality and rehabilitation is another interesting subject. There is a TED Talk about it and how to make rehabilitation, virtual rehabilitation, as if a patient is actually playing a game, which make it more engaging, more fun, less boring. And there are studies that suggest that this is something really could work for patients to improve their motivation and participation and adherence. However, most studies, unfortunately, are poor in methodology. They were small in size, and there was no control group. So you cannot draw a firm conclusions about the utility of these virtual programs. Other potential applications for telemedicine include meditation training, online meditation training, psychotherapy, and tailored phone calls. And these all were found in some studies to have a good impact, a positive impact on depression, anxiety, sleep quality, fatigue, and MS symptoms in general. What are the challenges to consider? So it's not all, of course, rainbows and cupcakes. There are a lot of matters that need to be addressed properly for the telemedicine to work. For example, the licensing requirement, which varies between countries, I believe. What platform to choose, which is the safest and most secure. Cost. Of course, the upfront cost can be a little bit high. However, experts in the field think that it's most likely offset by the decreased cost of no-shows, of face-to-face encounters, and all that kind of stuff. But then there is also the reimbursement. How would the healthcare providers be reimbursed for this kind of interaction with patients? Health information privacy, patients' confidentiality. How can we optimally protect patients' confidentiality during these kinds of encounters? And of course, the access to consistent networks in rural areas. If you're talking about extending your care, reaching for less privileged areas, then you have to make sure they have a consistent access to the internet networks. And of course, there is also a number of other obstacles, including, for example, lack of funding in some places, resistance by health professionals or patients, information, communication technology illiteracy, which I believe is not really a big matter, especially now after a lot of people had to use this kind of technology for their day-to-day, errands and tasks and work. Then there is the linguistic and cultural differences between patients and providers. Again, this was more pertinent to catering to patients to perhaps developing countries or less privileged places of the world. And then there's the legal considerations of this kind of practice. Like, for example, there aren't solid policies that regulate or govern the patient privacy and confidentiality, how to authenticate a health professional, especially if you're talking about these kind of interactions outside the boundaries of the hospitals, non-hospitals, and medical institutes, and also, of course, the medical liability for the health professionals. And then there are the technological challenges, including sometimes having to deal with complex systems, having also to deal with loss of stored data, and the potential for interruption and malfunction that might result in morbidity and mortality, and that is perhaps more pertinent to other branches of neurology or medicine, like, for example, telestroke, where things can be very critical very quickly, and also may render the healthcare provider liable. We also have to consider the legalities of telemedicine. We need solid regulations to be in place in order to protect the patient. For example, you might be talking to your patient online, and the patient might be recording the visit without your permission. There are many examples, but what scares me the most, the idea of cyber attack and loss of patient's confidentiality. Now, let's spend the second half, perhaps, of this presentation on the how. Now, like I said before, there are many platforms that can be used for video communication. And I think one of the most common platforms that we use frequently is the Zoom, but there is a good number of other platforms that can be used. Why not just over the phone? And I think perhaps this is clear, because basically you cannot do a physical exam over the phone, and you cannot properly and efficiently share lab results and imaging pictures or perform medication reconciliation. Also, when you video conference with your patient, you sort of gain a better understanding of the patient's circumstances, of the patient's emotion by seeing actually their facial expressions and body language. Video conferencing also helps you as a provider to gain perspective on the patient's living condition, as well as it does feel closer to the in-clinic face-to-face visits. Of course, if you are going to do a if you're going to practice telemedicine, you need to know how to plan your virtual visit properly. And there are a number of papers on that matter. And this includes how to initiate the encounter. You need to acknowledge the situation to your patient, make sure they understand what kind of interaction is going to take place, what are the expectations of the visit, what are the conditions in their side, be it the lighting, be it having or not having a helper around them, the proper positioning of the camera, the technical parts of it, as well as their readiness for neurological examination. And it is recommended that if you are conducting a virtual visit with a patient, to have a caregiver on their side to help with setting up the camera, setting up the whole tech-related things, and as well as how to help you with the neurological examination. How much time do I have? How much more time do I have? 5 minutes. All righty.
No, you have still 10 minutes.
10 minutes. Sounds good. All righty. Okay, so how to connect with patients through the screen, maintain eye contact. That's very important. Try to maintain eye contact, display sympathy. What do you say? You acknowledge that, you thank them they invited you to their home. You acknowledge that you hear them and understand how they feel, because it's less obvious online compared to the in-clinic visits. And then also acknowledge the newness of the situation. And that despite your typing, your eyes are on your screen, you do hear them and you do understand them. A group led by Dr. Awadallah, published in 2018, they validated the neurological 22 items of neurological examination when they compared these items done via telemedicine and on the other hand to those examinations done by experienced specialists. And they found that they were able to validate it, and we can use this in our online encounters with our patients. Now, there will always be challenges and limitations in terms of examination, neuro examination, for example, fundoscopy. Although, believe it or not, I came across an online application for online fundoscopic exam. I wish I included it in my presentation, but it wasn't very clear to me, but it does exist. So that is pretty interesting. Vestibular system, determined reflexes, also, for example, proper sensory examination, dermatobal and whatnot. These are things that are not possible to be done, but might not have a huge impact, and especially for patients who you already know and you're following up through via telemedicine. To improve tele-assessments, a lot of suggestions are out there, including a group of neurologists who think that, for example, sending a kit that is minimal price, it's very cheap, might actually help to perform things like the sensory exam on the patient's side, provided they have a helper. But what I find more efficient and more helpful is using the severity scale. For example, using the EDSS to assess patients with MS, and of course for other diseases, the severity forms also exist for the other diseases. One of the suggestions is to use the patient-reported disease steps, which was found to highly correlate with the EDSS, especially to the visual, pyramidal, cerebellar, sensory, and the bowel bladder, as well as the ambulatory function system, but not to the brainstem and cerebral function. So you can ask the patient to answer or to fill the form for the PDSS, and then when you see them, you can do the missing parts like the brainstem and the cerebral function. And then other tools for telemedicine and multiple sclerosis, like the MS severity, and MSIS-29 and the SDMT. And these all can be integrated to your assessment. So you can ask the patient to do things before the start of the virtual visit, and then when you see them, you can continue by doing the things that were missing. Tele-EDSS has been also compared to the in-clinic EDSS, and the correlation was high. And the conclusion of the investigator was that in mild to moderate MS, it's feasible the assisted stability, and telemedicine without the help, without any help at the patient's location, which was very, very useful. And then there is a number of applications that can be very useful, like, for example, the MS Test Suite, where this is just an example. You ask the patient, for example, to move the red circle towards the center. And by doing so, holding the phone, actually measuring several functions, including the cerebellar, the motor, and the visual. And then there is the mobile actigraphy, which patients wear around their waist or on the wrists, and it will measure things related to the gait and was found to have a strong correlation with the clinic-based assessment. And if you're interested to learn more about biosensors and wearable applications, then I recommend Dr. Lovarna paper in MSJ, Multiple Sclerosis Journal, published in 2018. It will help also to provide the patient with the tools for remote self-monitoring. And this is going to be helpful to detect changes before they present to you in the clinic. And we quite often see patients who do report relapses, small ones, perhaps, that did not bring them to the hospital. And it was difficult to objectively validate these relapses because basically they recovered by the time they presented to you. It also may empower the patient. When the patient monitors themselves, it empowers them. They start to become more proactive about managing their own selves. And it might actually, as suggested by the authors, level the hierarchy between patient and provider, and eventually translate to higher treatment satisfaction and adherence. So, remote self-assessment, many tools, including patient-reported outcomes, portable versions of the 9-hole peg test and the timed 25-foot walk test, online version of the very popular, commonly used cognitive test, the simple digit modality test, as well as other wearable technologies. So in conclusion, I believe that telemedicine in multiple sclerosis can be feasible and is an important complementary method in order to bridge the gaps and overcome challenges we face in everyday traditional healthcare system. It may help extend our specialized care to less served and less privileged areas of the world, but we do still need to exert some efforts to overcome logistic, legal, and technical obstacles, and definitely more research is needed to improve our understanding of the techniques, mechanics, and as well as cost effectiveness, safety, and reliability of telemedicine. Thank you very much.
Thank you, Dr. Muna. Excellent review for telemedicine, how to be used in the MS field. I believe we had the telemedicine for more than 15 years, 10 years now, but with the COVID, I believe what we are going to have in 2021, 22, huge change in how we treat our patients, the clinic visits, which will be reduced soon. But we, as you said, we have the good infrastructure, but we need to have the legal and the safety of the patient's privacy during these telemedicine sessions. We will keep the question at the end. We have few interest cases. We will go to Dr. Talib Al-Mansour, who's assistant professor, associated professor at Department of Radiology, UA University. At the same time, he's a diagnostic radiologist and neurointerventionist. Dr. Talib today will speak about the update criteria for diagnosing MS. Please, Dr. Talib, you can start.
Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. It's my pleasure to be with you today. Today's lecture will be an update. I'll be talking about the updated criteria and diagnosis of multiple sclerosis. The outline of my presentation will be, first of all, I'll speak about multiple sclerosis, the typical MR findings, as well as the variants. Then I will talk about the updated McDonald's criteria. I'll be solely talking about the dissemination in time and dissemination in space, which is mostly related to my field, which is radiology. And after all, at the end, I will be talking about the protocols that we use for diagnosing multiple sclerosis, for which I think many of you are interested to know, to optimize their protocols. And more importantly is the pattern of communication between the physicians and the radiologist on how to convey the message to each other for the sake of the patient's benefits. Okay. So as a start, multiple sclerosis is a very complex condition that continues to be challenging and disabling condition. But some of the fundamentals questions relating to causation and susceptibility have been answered through research and, a huge amount of budget have been put to answer many questions related to multiple sclerosis. And we can see that happening right now with the advancement of the modifying treatment patients are receiving. And the multiple sclerosis is predominantly affecting individual because they are affected in their, individuals in their early adult life. And this disease has a huge impact on their functionality and their financial status, as well as their quality of life. Now, the costs are considerable and raise with increasing disability. Now, early and accurate diagnosis is very important because that will affect the patient's quality of life. Okay. Now, most importantly, MRI can support and substitute the clinical information in the diagnosis of multiple sclerosis by showing disease dissemination in space and time while looking at the images. Now, before going into showing you cases, it's very important to understand some of the terms when dealing with multiple sclerosis based on the criteria. Now, you have to be aware about clinically isolated syndrome, progressive course, relapsing remitting course. I'm not going to go through them all. Radiologically isolated syndrome, for me, this is important because what I'm going to convey to the physician in my report, that I see many typical lesions for MS on the MRI. However, the patient is not suffering from any symptoms. Usually those patients will go for an MRI for other causes rather than searching for multiple sclerosis. That's why it's called radiologically isolated syndrome. I'll be concentrating on dissemination in space and dissemination in time. And dissemination in space is, for us, it's really important to look for the typical locations where these lesions can be found. Usually it's in the subcortical areas, the periventricular areas, the infratentorial, and the spine. These are the four main places where MS lesions can appear. Dissemination in time is the development of or appearance of new CNS lesions over time. So imagine a patient who is going to have a baseline MRI and you found a lesion in his periventricular region on today's examination, and on the follow-up examination you find a newer lesion on the contralateral side in the periventricular region, and that's what we imply where we imply about dissemination in time. So the typical places for MS, as I mentioned, in the periventricular regions, where you find these lesions on, you have to look for them on T2 and FLAIR sequences. This is a FLAIR sequence where you see a lesion along the trigone of the left lateral ventricle. Some of them are also found in the along the anterior horns of the lateral ventricles. Now, the image on the middle, it will show you the cortical and juxtacortical lesions. So this is more of a cortical lesion involving the parasagittal region of the right frontal lobe. Here, there are other juxtacortical lesions. So the juxtacortical lesions will be a few millimeters away from the cortex. Now, the European MRI MS group, in their consensus, they said, well, it's okay to combine them together because sometimes it's really difficult to identify which is which, and this has been, I think, adopted by the McDonald criteria in their revision in 2017. Now, the infratentorial lesions will be involving the brainstem and cerebellum. The spinal cord lesions will be involving the cervical part of the spinal cord. Now, this is a real example from my own practice. This is a young lady who was known for MS. She was found to have multiple periventricular white matter changes. So these are the regular FLAIR images, or what we can call them 2D FLAIR images. And these are similar lesions that are oriented perpendicularly to the lateral walls of the ventricular system. And these are called the Dawson fingers. I'll show you much better Dawson fingers in the subsequent slides. Now here we have some cortical, juxtacortical lesions also involving the left temporal lobe. Now here you can see involvement of the corpus callosum in this young patient. Now the overall size of the corpus callosum is smaller than usual, especially for a young female at the age of 33. So atrophy, I mean, corpus callosal atrophy as well as spinal atrophy is very common in patients with multiple sclerosis. So here, this is a better example for Dawson's fingers, where you see perpendicular orientation of these lesions along the wall of the lateral ventricle. And the engagement of the lesions in the corpus callosum here, it's along the callosociptal region. Now, these are other images that confirms the presence of cortical and juxtacortical lesions in the frontal lobe. And this is the same patient with the example of infratentorial lesions. Here on the right cerebellar hemisphere, you see faint lesions along the cerebellum on the right side, as well as the brainstem on the sagittal view. Now, these are 3D T1 weighted images. By saying 3D T1 weighted images, these are very thin cuts kind of sequences that will be measuring less than 3 millimeters with no gap in between, or sometimes the gap will be very minimal. Okay, it's very important to look at these sequences because you can check whether these lesions apparent or not. If you see a lesion that is hypointense in signal and darker than the rest of the brain parenchyma, it means that this patient is suffering from a chronic type of MS, and these lesions have been there for a long period of time. Now, other patients, on the other hand, will show a hyperintense signal on T1, and that will also indicate chronicity. This is a case of another patient who was suspected to have an MS, and she underwent MRI of the brain and the cervical spine, and she was found to have 2 lesions, one along the trigone of the left lateral ventricle, but without any enhancement on T1 postgato. I'll show you the spine image on the next slides. Now, her follow-up MRI after 1 year showed the disappearance of this lesion along the trigone, and she didn't develop any lesions in the rest of her brain tissue, either supratentorially or infratentorially. Now, the imaging features of multiple sclerosis, to sum it up, there are actually hyperintense signal on T2 and FLAIR sequences. These lesions will appear as in ovoid lesions in the periventricular white matter with orientation in perpendicular and lateral ventricles to the lateral ventricles. That's what we call it Dawson fingers. And chronic lesions will show hypointense signal on T1, and we call them black holes. And DWI can be bright, which is the diffusion weighted images, can be bright, which means can be restricted. I mean, if it's showing restricted diffusion, meaning that it's bright on DWI and dark on ADC mapping, it means that this lesion is active. And as I mentioned previously, those patients, despite being young, you will see some sort of atrophy involving the cortex, the spinal cord, as well as the corpus callosum. Now, abnormal cord MRIs were found in 83% of patients with MS, primarily 55.5% situated in the cervical cord, with a diagnostic sensitivity of 66%, which increased to 85%. Now, this is another example of Dawson's fingers. This is an example of black holes. So you see these periventricular white matter lesions along the wall of the left lateral ventricle and the right lateral ventricle. However, on the left side, you see them darker than the rest of the brain parenchyma. So this is what we call a black hole, which indicates chronicity. Now, this is another example of a patient with typical lesions for MS. Only one of them showed restricted diffusion. So this is the DWI and this is the ADC mapping. So here's the bright spot, which will be dark on the ADC mapping. So this is an indication for an active disease. This is an example of a patient with MS, which showing corpus callosal atrophy. Now, do they enhance? Yes. I mean, transient enhancement during active demyelination was seen in more than 90%. I mean, in most of the patients, but 90% of them will disappear within 6 months. The pattern of enhancement is variable. Some patients showed the nodular enhancement or ring enhancement, semilunar or incomplete horseshoe enhancement, and rarely these lesions will appear large and enhance. So this is an example of a complete ring enhancement. There's this patient was found to have multiple lesions actually in his brain. So we are able to see a ring enhancing lesion in the left parietal lobe and incomplete ring enhancement in the right parietal lobe. And there's this periventricular lesion in the right side, which is not enhancing. So whenever you see variability in enhancement, this is a clue that this patient is suffering from a demyelinating disease, most likely MS. Now the same patient with a ring enhancing lesion in the right frontal lobe, but at a different level, and another lesion that is showing nodular enhancement. Now, this is another patient with nodular enhancement all over the place. You see it in the corpus callosum, along the left frontal lobe, as well as the right frontal. This is another patient with, I think this is a tumefactive type of MS, showing a large mass in the right temporal lobe with vasogenic edema, surrounding edema, with a little mass effect over the adjacent parenchyma and the lateral ventricle. And you see this enhancement is ring type of enhancement. Now shifting gears to spinal cord lesions. So this is a 30-year-old female patient presented with upper limb numbness. Sorry for the typo. So our protocol will include sagittal T1, sagittal T2, and axial T2. So the patient was found to have a short segment lesion involving the upper part of the cervical spine. You see some hypointensity on the T1 weighted images, hyperintense signal along the cervical spine. But if you look at the span of this lesion, it doesn't exceed more than 3 vertebral levels. So it only span along 2 vertebral levels. So this is considered a short segment, and it involves the center of the spinal cord, as you can see it on the axial views. Okay, so this patient received GADO, and it showed enhancement along the lesion location in both the sagittal, coronal, and axial views. Now, this patient was put on steroid treatment, and after a couple of months, a repeat MRI or follow-up MRI was done, which showed almost resolution of the mass, but we still see it, but faintly, not as compared to the previous examination. This is a recent patient, a patient I saw recently, a 21-year-old female with MS, and she was found to have a small lesion in her cervical spine, along with a couple of lesions in the brain. So this lesion was enhancing after gadolinium administration, and she had a follow-up MRI after a year, and she was put on treatment, and both the brain lesion as well as the spine lesion disappeared, and you can only see a faint area of or residual lesion at the same area which was spotted previously. Now, I know that cervical spine lesions brings lots of problems to many of our physicians. So, because they have to go through a long list of differential diagnoses, but to make it easy, this schematic representation will I can give you a hint on what kind of differential diagnosis you have to generate depending on the location of the lesion you see on the axial view, along with the complementary sequences on sagittal view or coronal view. So for more details, if you see a lesion that is involving the posterior aspect of the spinal cord, you always think about multiple sclerosis, as we can see here. So this is a typical location for multiple sclerosis, as we have in this lady. The lesion is involving the posterior aspect of the cervical spinal cord, and it's a short segment, and it's enhancing after GADO, so there's no way it can be something else. Okay. Now, if you have a lesion that is involving the lateral aspect of the spinal cord, think about multiple sclerosis. Lateral and the medial aspect, also multiple sclerosis. If you see involvement of the anterior aspect of the spinal cord, it's less likely to be multiple sclerosis. Okay. And if it involves the center, as we have here, okay, think about multiple sclerosis. Okay. Now, how do we look into these lesions on sagittal views, whether they are short or long? So a long segment will span along 3 vertebral levels. A short segment won't go beyond 3 vertebral levels. Now, we'll be talking about the MS variants. So this is an example of a patient of one of the MS variants. So this lady presented with an onset of pins and needles in her hand. She underwent a CT scan of the brain, which showed a solitary hypodense lesion involving the centrum semiovale of the left hemisphere, cerebral hemisphere. And an MRI was done, and it confirmed the presence of a mass with multiple different layers. Okay. As we can see it here in the flare, axial flare, sagittal flare, and sagittal T1. Now, this is another example of a similar case where we see multiple lesions with the different intensities. Now, usually with the and we have the DWI, it will show restricted diffusion of the border of this lesion, but not the whole lesion by itself. So here, I was talking about Bell's concentric sclerosis. It is a variant of MS, and usually it's a rare variant of multiple sclerosis with the pathologic hallmark of concentric rings of demyelination. It can be seen as a solitary mass and less commonly as a multiple lesion. So here I have 2 examples of a solitary mass or solitary Bell's lesion and multiple Bell's lesions. Okay. Now, the cause of concentric demyelination is tissue preconditioning and hypoxia-like injury, unlike classic MS, which has something to do with the T lymphocytes and macrophage-dominated inflammatory demyelination. Unlike MS, which can present with subclinical and reversible deficits, Bell's lesion can have sudden acute onset symptoms and rapid clinical deterioration. Now, the imaging features of Bell's lesion. Acute lesions show alternating bands of different signal intensities on T2 weighted images. It has been described as a whirlpool or the tree trunk or the onion bulb, and some others will describe it as a fried egg. Perifocal edema is common. Diffusion restriction is seen in the outermost rings of on DWI. The active demyelinating layers enhance on T1 post-Gallo sequences. Other more typical MS-like plaques can be seen also present. Now, this is another example of tumefactive MS, which is another variant for MS. This is a case of a 28-year-old male presented with the first time seizure. An MRI was done and was found to have this mass involving the right temporal lobe. As I showed you the enhancing image of this patient earlier. So you see that this mass is hyperintense associated with the perilesional edema and has little mass effect over the adjacent parenchyma and the ventricular system. And it doesn't show any restricted diffusion because it's hypo-intense. It has a dark signal on DWI and bright signal on ADC mapping. That's what we call it. Okay, it's not restricted diffusion. On T1 post-Gatto, the lesion is showing incomplete enhancement. The imaging features of tumefactive MS is defined as large, more than 2 centimeters demyelinating lesions mimicking brain tumors, and it's associated with with vasogenic edema. It will show incomplete or open ring enhancement, and in dynamic T2 weighted images, you'll see vessels going through the mass. So that is diagnostic for MS lesions. Shifting gears to McDonald's criteria. So lately, in 2017, there has been revision for the 2010 McDonald criteria. So they mentioned that dissemination in space can be demonstrated by one or more T2 hyperintense lesions that are characteristic for multiple sclerosis in 2 or more of 4 areas of the CNS, the periventricular, cortical or juxtacortical, infratentorial brain regions, and the spinal cord. Now, dissemination in time can be demonstrated by the simultaneous presence of gadolinium-enhancing and non-enhancing lesions at the time of, or by new T2 hyperintense or gadolinium-enhancing lesions on follow-up MRI. Okay. Now, this is a comparison between 2010 and 2017 McDonald criteria. So they are all the same, but in terms of dissemination in space, everything is the same except for the symptomatic lesions in patients with in the brainstem and the spinal cord has been abolished in the current criteria. Dissemination in time, everything is the same, but CSF, specific oligoclonal bands have been added to be a part of the dissemination in time. So in summary of the changes, dissemination in space, MRI, cortical and juxtacortical lesions are equivalent to fulfill magnetic resonance criteria of dissemination in space. Dissemination in space and time, MRI, the distinction between asymptomatic and symptomatic MRI lesions have been discarded or abolished. And dissemination in time, CSF oligoclonal bands restricted to the CSF can serve as a substitute for temporal dissemination on MRI at the CIS stage. Now, what were the consequences of the new criteria? There was this article, research or publication in the Current Opinion of Neurology published in 2019. It shows an overview of the first real-world data. So here they summarize the data, the findings of 3, 4, 5, 6, 7 publications. So in the first publication, for which they applied the new McDonald's criteria, they concluded that the time between CIS and MS diagnosis has been shortened. Now, the second publication showed that the change of there was a change in the diagnostic approach. The third publication showed that the criteria showed higher sensitivity, but a potential decrease in specificity. Another publication showed early establishment of MS diagnosis. Another publication concluded that using involvement of the optic nerve as a criterion for DIS leads to higher sensitivity and lower specificity. So inclusion of the optic nerve was not incorporated in the 2017 McDonald's criteria. So those guys adopted what the European MS-MR group has included in their consensus. And one group I think they compared in applying the McDonald's criteria by using a 3T Tesla MRI in comparison to 1.5 Tesla MRI, and they didn't see any difference. Now, regarding the MR protocols, the people responsible for the McDonald's criteria, they always refer to the consortium of the MS centers MRI protocols. So they have a document available on their website, and it includes everything physicians need, either a neurologist or a radiologist. So looking at their latest guidelines were published in 2018. So the baseline studies for patients with clinically isolated syndrome and or suspected MS, these are their guidelines. So brain MRI protocol with gadolinium at baseline has to be done to establish dissemination in time later on. Now, spinal cord MRI, if myelitis is insufficient with insufficient features on brain MRI to support diagnosis in patients above the age of 40 with non-specific brain MRI findings. Now, a cervical cord MRI performed simultaneously with the brain MRI could have prognostic value in the evaluation of clinically isolated syndrome patients or without myelitis, and would reduce the number of patients requiring subsequent MRI appointments. Now, orbital MRI, if a severe optic neuritis with poor recovery, can be also done. Now, what about the timing for follow-up for such patients who present with clinical, with the CIS, clinically isolated syndrome, or suspected MS? Now, the timing for follow-up brain protocol for patients, for such patients, to look for evidence in this, of dissemination in time, can be done. I mean, they categorize them into two groups, a high-risk group and low-risk group. If your patient falls into the high-risk group, you can do it between 6 to 12 months. Now, if your patient is in the low-risk group, you can delay the follow-up MRI and do it in 12 to 24 months. Now, clinical syndrome with suspicious brain MRI features also would warrant a follow-up MRI. Now, what about the timing of a follow-up MRI for established MS patients? Now, you have to do it as a baseline if no recent prior imaging available, or you just received this patient from somebody else or he was referred to you and you are seeing him for the first time. If you had the patient who was diagnosed with MS, and especially ladies who were pregnant at the time of diagnosis, you can establish a baseline MRI postpartum. Prior to starting or switching disease-modifying therapy, that will warrant a baseline, an MRI as well. Approximately 6 to 12 months after switching disease-modifying therapy to establish a new baseline is also recommended. Now, so I'm not going to go through them all. They are all listed in their booklet and guideline, and you can refer to those. When to use gadolinium-based contrast agents? Usually, you use gadolinium at baseline and with patients whom you think they are suffering from an active disease. Sometimes you would discard using gadolinium-based contrast, especially if this patient has been being followed up for many years. Now, this is the protocol of the consortium of the MS centers that they recommend. They recommend actually for core sequences to do either 2D or 3D sagittal and axial flare, 2D or 3D axial T2, axial 2D DWI, and 3D T1. Gadolinium is required at baseline. And additional sequences will include SWI or SWAN, along with 3D gadolinium, 3D axial T1 post-gado. So this is for the brain. The protocol that I'm using in my hospital is the one I'm showing you on this slide. I start with, I always ask my technician to do a 3D axial T1 for me. It will be useful to look for black holes. 2D axial T2 is a must because of, and the 3D axial flare. Now, the difference between a 2D and a 3D flare is the thickness. The slice thickness of a 3D axial flare is very thin. We're talking about 3 millimeters and below. But with the 2D, it's usually 5 millimeters. Now, each one of them will have pros and cons. Now, the thing with the 3D axial flare, it will require more time, and that will cause some delay in scanning your patient's list, actually. And the other sequence I request always is the 3D sagittal flare, axial SWI to look for any microbleeds, axial DWI to see any restriction, and a 3D axial sagittal and coronal T1 post-gado. Now, this is a slide showing the difference between a 3D and a 2D. So the one on the left side is 2D, and the one on the right side is a 3D. So you can see the clarity of these lesions on the 3D images as compared to the 2D. Some of the lesions, especially this one, is not clearly conspicuous on the 2D image, but the one along the periventricular region, I'm referring to this one here, even the other one next to it, they are bright and very conspicuous on the 3D image. Now, if you look at the infratentorial lesion involving the cerebellum, is not seen actually, but you do see it here on the 3D.
Dr. Talib, we have 2 minutes left, please.
Okay. Now, this is the recommendation for spinal MR. So I'm not going to go through them all. Now, this is the protocol I'm using in my hospital. I always request sagittal T1, sagittal T2, sagittal stir, and an axial T1, and a sagittal T1 post-gado. Now, some institutions, and there have been many publications about using a T2 star weighted sequence for spinal and musculoskeletal imaging. Now, depending on the machine you have, each machine will have a name for its sequence. So T2 star and GE is called MERG. Siemens will be called MEDIC, and Philips will be called MFFE. Yeah. Now, this is an example of a T2 star and a T2. Now, a T2 star image will show you bright, you will be able to see the lesion very clearly as compared to the T2. Now, this is an example of a T2 sequence where there is a flow artifact, okay, hindering the CSF space anteriorly. As you can see it also here on the sagittal view. This kind of artifact is not seen in the T2 star. Okay, so how do we communicate between physicians and radiologists? So as a physician, you have to clearly indicate what's your question by writing up the diagnosis and monitoring for management decision. You should show relevant clinical history and physical examination finding in your request. Current MS disease modifying treatment has to be included. I know it's very busy, and I know it's busy for physicians to write up all these details, but these are the recommendations of the consortium. Now, my role as a radiologist is to have a standardized report where I have to describe the findings, the location of the lesions, the sizes, and what has been, I have to compare it with the previous examination, and to give the physician the whole picture about the current status of the patient. So in summary, a brain MRI with gadolinium is recommended for diagnosis of MS. A spinal cord MRI is recommended if the brain MRI is not diagnostic, or if the presenting symptoms are referable to the spinal cord. Follow-up MRI is recommended in these situations. Thank you very much.
Thank you, Dr. Taleb. A very nice presentation, went from A to Z regarding covering all the sequence for the different subtypes of MS, spinal cord lesion, black holes, and the variant of demyelination. Jazakallah khair. I would like to ask Dr. Muna Khoja to come back to join us and to start our questions. مرحبا دكتورة منى. So yeah, you are mute. So we have less than 10 minutes, so I will try to summarize all the questions very quickly. The first question that came is for Dr. Muna, is saying the following: I agree the effectiveness of telemedicine, but also believe the personal visit is very important to talk to the physician. Eye contact, emotional pain, that's very important, plus the physical examination. I don't have experience how much patients will feel satisfied regarding these telemedicine. What do you think, Dr. Muna, in your subspecialty?
Thank you very much for this question. I totally agree with the colleague who asked this question. That's why I emphasized in my presentation, if you recall, in the conclusion, that virtual care should be a complementary, but should never replace the human, like face-to-face in-clinic visits, but can be very helpful as complementary to the standard of care. Patient satisfaction, from that point of view, I have a personal experience. I've been working from home during my last few months of pregnancy. I was exempted from coming to the hospital because of COVID. And when I called my patients at the end of the call, they were pleased and satisfied. It was very unusual that the patient would request to see me soon again. But again, this could be biased because we were in COVID, and they don't want to come to the hospital. It's risky. So all in all, I was able to achieve my goals. They were only phone calls, by the way, because I was not using the virtual clinic facility in the hospital. I was calling them from home, and yet we were able to achieve our goals. From my perspective, satisfaction was very good.
And the second reason is Dr. Muna. I know how the patients adhere and close to Dr. Muna. So when you will call them, 100% they will be satisfied with that.
Thank you so much.
Thank you, Dr. Muna. We will try to make the answer very quick, Dr. Talib and Dr. Muna. So one question: how to differentiate, Dr. Talib, between tumefactive type of MS from glioma?
Well, you have to actually request more sequences. You have to request spectroscopy and perfusion imaging. You have to go through the spectroscopy parameters and the metabolites. With the spectroscopy of gliomas, there will be the choline creatinine ratio will be high, actually, which is not seen in tumefactive MS. But the most important thing, if you are going to have a mass, okay, that is glioma, you will see mass effect all over the place. This patient, if the patient I just showed you had a glioma, he will definitely have hydrocephalus or subfalcian herniation.
Okay.
Yeah.
Clear.
Yes.
Dr. Muna, a question: is there any potential risk associated with telemedicine? I think you came across that one through your presentation. If you can just summarize it quick.
Yes. First of all, as we said, in virtual visits, it's not super sensitive to minor changes in examination. Things might be missed. Moreover, there are the risk inherent to using technology and conducting visits. For example, hackers, loss of confidentiality, loss of data, misunderstanding sometimes, the need to see the patient again too soon, so that which is overuse of resources, and others as well.
Dr. Mona, again, another question is, do you think in the next 5 to 10 years that we are going to, between two brackets, lose few of our clinics or subspecialty? For example, today I was attending the Saudi Stroke Society conference, and they spoke about the rapid software and artificial intelligence to read the MRI and other modality of neuroimaging. Second thing is, are we going to lose our clinic also, where we will be doing our clinics from home or office without seeing the patients, or cancel some of our clinics? The same thing with the with a few other tests that patients can have it from home. I mean, blood investigation, or they can do it from their primary care, primary clinics or their GP, and you will see the report from home. Are we going toward that direction with the telemedicine?
You know what? I think this is an excellent question and very interesting question. And the wider your imagination, the more answers to this question you can have. But I think that we will definitely, the face of the practice will have a major lift. We will have major changes in the future. I don't think we're going to lose our quote unquote specialties or clinics or jobs, but it's going to be different. It will look different. It will be more efficient. We probably will work smarter rather than harder to achieve our goals.
Same questions to Dr. Talib. Dr. Talib, radiology is one of the field. Artificial intelligence is expanding like crazy, and we are having many software which is able, for example, just I came across a paper of using artificial intelligence for the COVID patients for reading the CT and chest X-ray. Are we going toward that area? And it showed those study that the specificity and sensitivity of these software is equal, maybe better than the general radiologist.
Well, now everybody is talking about artificial intelligence as, is going to replace the human, a human being. But the way I look at artificial intelligence is a complementary addition, complementary tool for our practice. And as Dr. Mona said, it will make us work smarter than harder. Now, for example, if I have a long list of patients, I have to go through the whole day, and I'm going into a timely order depending on which patient came before the other one. If I have this artificial intelligence program running in the background, and it can identify the critically ill patient who needs an attention, it will highlight to me that this patient has a red flag, has to be treated on an urgent basis. It will notify me, and I will notify the physician about that ill or sick patient, so we don't lose time, and that patient will get the treatment at the right time.
Dr. Mona, are you going to establish after Mabruk, after you delivered, and if the vaccine is coming and all the normal life is coming back, are you going to establish the MS artificial or telemedicine clinic in your hospital, and how frequent you will see your patients in the clinic if you're using that telemedicine?
I'm already running a virtual clinic in King Faisal Hospital, and I'm expanding the number of virtual slots that I'll be seeing every week, and it's very helpful for patients from outside Riyadh. And I seriously actually considered creating or establishing a virtual MS clinic standalone, but that would definitely need a lot of work for future to be something, like a standalone beside the hospital work. But I think this is a very attractive option for many physicians, and maybe for mother physicians as well, who want to stay home longer than usual.
Agree. Last question, Dr. Talib, then we will finish here. Brain atrophy and MRI in MS patient. Do we have any? Do you have anything to add in this area, because it's very new area, which is all the researcher in the MS field, they are speaking about the brain atrophy. Early brain atrophy indicate of poor prognosis and poor outcome.
Well, to be honest, I'm not aware about the clinical the clinical presentation of such patients. But for me, as a radiologist, when I look at the brain of somebody who is at the age of 20 or 30 or even 40, with widened subarachnoid spaces, or the bulk of the major structures in the brain are not compatible with the age of the patient, that is alarming. Now, suppose you have a patient who is in his 70s and he's having dementia. Okay, the first thing you would think about is he might have a brain atrophy, right? A frontotemporal or whatever atrophy he has. And if you look at his brain MRI, you will confirm the diagnosis by this atrophy. But if you have somebody in his 20s or 30s with an MS, okay, and he's coming with some neurological symptoms attributed to brain atrophy, that's really alarming. And the only causative pathology in his case is MS.
Interest.
Yeah.
Thank you, Dr. Muna. Thank you, Talib. Thank you for all the audience. We have a great number of people who attended today our seminar. It was a great 2 days about update in MS, which has been supported by Novartis with a collaboration with the Emerson Neurology Society. I would like to mention that all the CME will be sent to the attendees, plus all the 2 days seminars will be downloaded on the YouTube channel of the MS. Wish you the best. Thank you, Dr. Muna, again, and thank you, Dr. Talib. Thanks for MCO for this support. Thank you. Assalamu alaikum.
Thank you very much.
Thank you.